Onza, mate. Onza.
Let's do it.
Let's do it. Okay, thank you for joining us for this talk on a practical approach to running assessment and injuries. I'm Alex Bell, physiotherapist and founder of The Running Room, and I'm joined by not only a great friend of mine, but absolutely amazing physiotherapist. He's the founder of Freshman Physio. If you haven't checked them out on Instagram, get around it. Huge value there. And exciting to announce that he's the co-director in The Running Room London. I'm joined by Adrian DaCosta. Mate, thank you for joining us.
Thank you for having me, mate. And good day to everyone. Nice to meet you guys, and hope you guys get a ton of value from this prezo.
Absolutely. So me and Adrian were talking and we thought, what is this talk going to be about? And what is this talk? How can we bring the most value to you as podiatrists and allied health practitioners alike? So I think if we were going to chat about one thing, it would be that when we talk about running assessment, I think that there's more than biomechanics. And I think if everyone left with that message, I think that our job would be done really, really nicely in that. We know we have to think of running injuries are multifactorial. There's more to the running than just biomechanics. We need to think about the whole ecosystem and what that looks like. And then starting to think, well, how can we actually add value to a runner and get them better, not only from, the injury perspective, but how can we take them from injury to performance and really, build happier runners who run injury-free, if there is such a thing, and how can we get them running, faster, longer, and stronger? So that's the approach of today.
No, for sure. I think it's important. Sort of the biopsychosocial approach. You sort of hear that being thrown around, and let's sort of dig into it and obviously give you guys a bit of perspective on each element.
Yeah, I think probably the other thing to touch on is that you're all over the research. You love it, the work you do with freshmen, but I think we're both clinicians as well. First and foremost, we treat runners on the daily. And I think we've got a lot of little gems that we might see clinically as well, and how we can apply that to that clinical population. So I think this will be a good one.
Yeah, man, for sure. I mean, just on that alone as well, like the research is great. It's our guide, but not all research is pragmatic. Some of the research, you look at it and you go, there is no way I can implement this in a real world setting.
Yeah.
So you really got to look at it and then obviously look at it in your setting, but then also go, how applicable is it to the person in front of me? And that's the most important thing.
Yeah. Love that, mate. Love that approach. So let's just kick off with some objectives. What is running assessment and why is it important? Who do we assess? Who do we need to assess? And what do we need to look for? And really touching on, that there's more than treating a runner than just the biomechanics. We're going to go into injury versus niggle. What's the difference? And I really like this question. Like, is running with pain always a problem? I think we'll touch on that. But if we told runners not to run every time they felt some pain, they probably wouldn't run a lot. So navigating that issue and seeing when is it safe for someone to continue to run and when is it probably not so safe. Highlight the importance of load management in the runner. And this is probably the thing we do most in the clinic, and probably the most important thing that I think personally we do as clinicians is managing load appropriately, and really looking at some strategies we can do that. I think we're going to go into load versus load capacity, explain what we mean by that, the 10% rule, and probably highlight that it's not so optimal and a little outdated. And then touch on some newer things like the acute chronic workload ratio. It's also not perfect, and there's some literature that's come out about that. But I think it's a nice way to look at some other things that are related to load. And then I think if we look at the whole ecosystem, the person, what are they doing outside of running, and highlight the importance of recovery on injury risk. And we can probably include performance in that as well. I think sleep there will show you some literature that's come out in more recent times looking at the importance of sleep in managing the runner and also the athletic population. And a big one for us in the clinic is highlight the importance of strength training in the management of runners and running related injuries, not only to decrease the injury risk, but also to increase running performance. Let's kick it off, mate. I always like to think about this when I'm assessing runners or when I get someone in the clinic. I always start with the why. It's a question that I ask every single runner that walks in the door. Before I even assess their injury, before I even talk to them about what's going on, I ask, why do you run? And I think it's a really important question to ask. People run for a multitude of reasons. I think we all know the physical benefits that running provides for the human body, but we need to really touch on the importance of the mental factors that running plays in mental well-being, mental resilience, things like that. And I think anytime you're dealing with a runner who's running for those reasons, it's really important to highlight and probably take them on that journey to get them back to running, or at least provide strategies where they can still remain physically active, because it's such a big thing that they implement in their daily lives to improve their mental well-being. Yeah, massive. I don't know. I mean, huge for you. I know, we've spoken about this, but that mental side of running.
It's like, especially at the moment, like in London, I know with Australia, things are quite relaxed at the moment, and, lockdown isn't really lockdown in comparison to how we have it here. But there are a lot of runners here. You're starting to see that, running is really their only avenue at the moment to really get a release and a mental release from, life being so restricted. So if you don't approach that and don't understand that element of the runner, and you see, say, an injured runner in front of you, and the first thing you do is you absolutely stop them from running, where there may potentially be a way to keep them running, whether it's even doing a run walk interval, and you don't offer that on the table, it can really have an impact on, their rehab, their buy-in to what you're saying. And, we really have to keep that as a crucial component to how we assess that person in front of us.
Absolutely, mate. Couldn't agree more. And we've seen that even in Australia with gyms shutting down, over the last 12 months. Periodically, we've seen a massive transition in people wanting to get outdoors. The weather's probably a little bit better here where I am, than yourself in London. But a lot of people want to get outdoors and wanting to get active and want to move. So we've seen a massive spike in the amount of runners that we've seen in the community and the runners we've seen in the clinic. I think injured or uninjured is a big one that we see. Originally when we started the running room, we thought, yeah, we'll see a lot of injured runners, but that's been a big shift for us in the last 12 months. We're getting a lot of runners who are uninjured looking for, hey, how can I manage my load better, and how can I increase my performance, and how can I stay injury free? So I think, that's a really good place to start, and it moves from, rehabilitation, prehabilitation, and then into that performance. We're always talking about the running journey and taking the runner on that journey, from pain to performance. So I think that's a big one. And then why else would you assess them? Well, they do get injured a lot. We're going to present some stats there that runners do get injured, and it's a really big part of running. I think if anyone's listening to this and is a runner themselves, the chances are you've probably sustained a running-related injury. And it plays a big role. We touched on this in the mental health of people who run. And I just think that the last one is, don't forget all the sports or training that involves running. When we think about other sports, a lot of people will use running as an outlet to build fitness. And so it's a massive reason to assess someone's running.
Yeah. And I think in some runners, like it's, they might have, they might tick all those boxes and go, yeah, mental health is good, running technique is good. They're probably doing some decent strength work but need some update. But then probably lack just good education around how to run, when to do your strength work. And don't neglect the importance of the advice and the education that you give them. That itself is worth its weight in gold. Absolutely,
mate. It's something that it's probably the most important thing, I think, when we're addressing runners is education. Education on many things, but that's at the forefront of what we do in the clinic. Let's touch on this. This may be the most important slide in the whole presentation, and that what is running assessment? It's much more than running biomechanics. We need to take a person-centered approach. We need to look at the individual in front of us. And when we talk about biopsychosocial factors, we need to actually touch on what does that mean, and are we actually taking a biopsychosocial approach to managing these runners? All injuries are multifactorial. It's not just, you're overstriding or your hips dropping. We really need to start looking at some of the person-centered approach and look at that individual in front of us and see, hey, is there more at play here? Because more often than not, in fact, every time there is going to be more at play than simply their running biomechanics. I think that, a good subjective when you're treating any runner is the key to your treatment, and is the key to getting someone or taking someone on that journey to improving their outcomes.
I definitely agree there. I think, these are all key components. And then, what I probably would add there as well is just a little component about, socially, how are they running? Are they running by themselves? There are a lot of runners that do that, but things like park run clubs are crucial. And how do these clubs affect someone from the social interaction?
Yes.
But then if you go to the nitty gritty of running, is someone running alongside another runner who is probably a little bit quicker, and then they're trying to keep up. And is that potentially a reason for a bit of breakdown as well? So really sort of getting into that person's running history and sort of, you know, what each element of running means to them and what each run means to them.
Yeah, absolutely, mate. I always like to think about the flow-on effect that we can have, or we can, you know, assist with as clinicians, in that, you know, think about someone who runs for that reason, the social interaction, you know, the mental well-being, and then think about taking that away. You know, think about what impact that may have on that individual, not only on a personal front, but at a community level, as a father, as a work colleague. And, you know, if we can keep them active, we can keep them, you know, moving and running, what flow and effect does that have to someone else's life? You know, are they a better person to someone else? And then, you know, all these flow on, there's no real ROI on that stuff, but I think it's a really nice way to think about it. And I think in times like COVID, it's been such a powerful tool that many people have been drawn to and many people have used. So I wouldn't discount, you know, the effect that we can have on someone's life as a clinician here by treating runners. And I think it's a beautiful thing to think about. Let's move on, mate. Running related injuries. I love this quote. I think it was CJ who said it, Chris Johnson. If any of you guys are not following his work, you need to get around him. Absolutely brilliant communicator, brilliant clinician, and really, you know, around the research as well. He's a really, really good guy. So look him up if you haven't already. I think he said this: the only way to truly prevent running related injuries is to not run. And a little bit of tongue in cheek there, but it's true. You know, like running related injuries in the literature, we see anywhere from around that 20% mark to 80%. And so it's hugely common to sustain a running related injury. And I think it's one of those things that we really are going to have to deal with if we're going to have to run, you know, and we'll touch on a little bit of injury versus niggle in a couple of slides and look at, is it okay to actually run with pain? And I think in many cases it is, you know, within reason. And we'll explain some things that we can implement easily in the clinic to sort of track that stuff. Anything to add there, Ray?
No, I completely agree. Like, you know, the research there obviously is, you know, dictates, you know, the levels of injury and what's sort of most prevalent as well. But yeah, like, you know, you really need to factor in, and I think we're going to cover this in a few slides, is like pain versus soreness versus niggle, and sometimes the education around that and what is appropriate.
Mm-hmm. Absolutely, mate. Where do runners get injured? Well, knee pain, we know it's really common. The knees is the most common running related injury. I think probably it's one of the better ones to treat, though. You know, I think there's many modalities that we can implement from a clinical perspective to manage knee pain. You know, from education to load management to some biomechanicals, and gait retraining often responds quite well, and some really good quality loading. I think it's really, really important there. Then we see lower leg injuries, foot and ankle, hip and pelvis, and then thigh injuries as well. So, you know, if anyone's treating runners, I'm sure they're all across the fact that, you know, you've probably treated many, many knees in the clinic.
Yeah, I think the only thing I would probably add to this is, you know, these areas get injured, but one thing we also do know from the literature is that most running related injuries is due to training error as well.
Yeah.
So sort of like highlighting people's training and understanding, you know, what types of runs they're doing, how often in the week, when is their rest, their recovery. And then obviously we're going to touch on a few things with respect to sort of load, both sort of acute to chronic as well.
Yeah, absolutely. So who's most likely to sustain a running related injury? And again, I would like to highlight this by saying that exactly what Adrian just mentioned, you know, running related injuries are always multifactorial. Training error is a big one, but we do see in the literature that, you know, novice runners are more likely to sustain a running related injury. So we're talking runners who have been running for less than 12 months in this case. And we said that they are more likely to get injured. I think if you've had a previous injury in the past 12 months, you're more likely to be injured. And we know people or runners with a high BMI often get injured more. And then this is the big one, that sudden changes in load play a role in running related injuries. And so managing that load appropriately and educating runners on how much is too much. You know, do you need to have more rest into your week? How can we best navigate the landscape of training load is hugely important there as well.
Yeah, definitely. I think that there's an element here where like sustaining like running related injuries is like if you've previously had a running related injury, how often do you get a runner who comes in that is doing quite well but just is paranoid and just has this sort of element of like they just constantly feel this niggle, or they just can't mentally get over that hurdle as well. So you know that sort of psychological component related towards a previous injury can play a huge factor as well. So sort of really understanding what can you do with what you have in your toolkit, from getting them more resilient and helping them sort of get confident with their running again as well.
Absolutely. And I think we'll explain that boom bust cycle that we see so often in the clinic when we talk about load and load capacity and how we can best navigate that issue. Mate, a good segue into niggle versus injury. And I know we could bang on about this for a little while, but I think a real practical approach to this, and how I often explain it to my patients, is that often an injury is something that you will suffer from. It could be a muscle tear, something where you're running and you cop something, it stops you in your tracks. Hey, presto, you can't run on. I think we do see them obviously more likely in the sprinting population when we're talking about runners, but we do see them a lot also just in everyday recreational runners also. I think when I explain a niggle to a runner, I'm talking about something that may present itself. You may feel it, it may build, you may neglect to manage it appropriately. You may not do something about your training load, and over time it builds, and subsequently that then becomes a running related injury that stops you from running. I mean, how many times have we seen patients in the clinic whereby they come in and we say, how long have you had this? And they might say, 3 to 4 months. And I really think that it's okay to run through niggles, but there's probably some really practical things that runners can do to make sure that niggle doesn't turn into an injury. Have you got anything there, eh?
Yeah, I think you hit the nail on the head. Is like that running load, like with a niggle, you might not need to change your running load, or the change or the adaptation running load might be very sort of minor. So it might mean you go from 100 Ks a week down to say 95 Ks a week or 90 Ks a week, but you're still keeping really high volume.
Yeah.
Whereas an injury can really have, two impacts. It could stop you at your tracks and stop you from running altogether. And that's at the sort of like end spectrum. Or it could really dip your running load, right? You can have something like an Achilles tendinopathy, which is quote unquote an injury, but you're still running, but you're not running 100 Ks a week anymore. You're doing 50. So your running load and your capacity is dipped, a fair bit. So I think that's sort of how I look at the two there.
Absolutely. And I think it's very different for different injuries, but I think we're going to show that when someone has a niggle, what are some of the things we can do to actually increase the capacity of that tissue to withstand load? And what are some of the things that we can do to not offload, but shift load around? And there's many things we can do as clinicians that can really assist the patient from having a niggle that doesn't turn into an injury, and can continue to keep them running, keep them moving whilst we manage that niggle. This is a big one for me, and I always explain this in a really simplistic way to patients, and it's load versus load or tissue capacity. Now, I always explain it like this. If we've got how much load you're doing on a weekly basis, and when there's nice slide coming, but we know there's many things that feed into that. It's not simply just volume of running. It's how much running you do, yes. What does that running look like? What frequency do you run at? How much sleep do you get? What are your stress levels? What's your diet like? What's your past injury? There's all these things that will feed into your training load. And then we think about load or tissue capacity, and we think about any tissue in the body having a capacity to withstand load, whether that's bone, muscle, tendon, ligament. If we think about a runner's load and how much they're doing, and once it exceeds that of your tissue capacity to such an extent, the patient may get symptoms. Now, we can often sneak this up and tolerate that load being above your tissue capacity for a little bit. If it's not too great, that increase, and it's not too great over time, often what we'll see that is it won't have an issue. But if it's too great, then someone may get injured. And then typically what we see in the clinic a lot is, well, what do I need to do? I need to rest. And what happens is your load goes well down, but your tissue capacity does not stay up here. What happens at that point is your tissue capacity will come down as well, particularly if you're not doing any of the adjuncts that we might give people whether it's, strength and conditioning, things like that will actually build that capacity. And then runners get stuck in this cycle, we call it boom bust, where they rest for 2-3 weeks, their pain goes away because they're not running, and they go back to that training load that they had previously held, and hey presto, their injury comes back. And then they go, I didn't rest for long enough. And then they subsequently rest again. And all of a sudden they're getting stuck in this cycle where their tissue capacity is being subsequently reduced, and they're just stuck in this boom bust. So we need to really approach that with, what are the things that we can do to manage not only training load, but what are the things that we can do within the clinic and within someone's training that can build load or tissue capacity? I think it's something that's massive part of what we do, eh?
Yeah, for sure. I think you've touched on two bits there, and I'll sort of address them. The first one being sort of like, I always think when I see this slide here, I think about Tim Gabbett, and he says something along the lines of, it's the load that you're not ready for, the stuff that you haven't prepped for that typically will get you injured.
Mm-hmm.
And I think that relates to that load capacity. So, how big is your bucket? Can your bucket withstand the water, the liquid that you're putting in there?
Absolutely.
And if it's not, then we've got to get that bucket bigger. And you do that through different things. You do that through obviously a modification in their running training, but also then trying to get their capacity and their tissue capacity up. And that's where strength training comes in. And then, you said the classic sort of running thing is like, I'm injured, I'll rest, I feel good, I'll go back to running. Shit, it's still there. So, and you end up sort of having a couple issues there. Firstly, you actually haven't addressed the tissue capacity to get it bigger. But then, say there's a runner that hasn't run for 6 to 8 weeks because they feel like, this is a pretty nasty injury. We know that in this period of 15 to 30 days, you lose adaptation and positive adaptation in all your training effects. So, in 15 days, you lose your cardiovascular effect. You lose probably speed effect way quicker than that. You lose like speed effect probably in like 10 days. And then your strength training, if you do some level of strength training, which most runners tend to neglect, strength training, you get that sort of like window that it gives you afterwards for about 30 days. So, if you've rested for say a month and a half, you've lost all effect. So now your capacity, if you had a bucket that was 10 liters or 10 kilometers worth, let's go with the running load. Now, you might not even have that. So it's important to know that, with this, when you've seen an injured runner, is putting these two into perspective, but then also looking at the rest to relative rest sort of relationship as well.
Absolutely. I think of a patient that I actually saw this week in the clinic, and it was a tendinopathy patient. And I think this boom bust is ever prevalent in that tendinopathy type patient. The patient who is often prescribed rest as well. We get a few people that will come in and say, oh yeah, I've had this for about 6 to 8 weeks and I was told to rest or stretch it. We know that probably doesn't build capacity. And we need to apply some really nice load to build that capacity and allow someone to continue running. So it's something that we often deal with, a hell of a lot in the clinic.
Yeah, for sure.
I love this slide. It takes us to Tom Goom, the running physio. Your mate.
Shout out Tom Goom.
Yeah, your mate over there in the UK. And I just think there's a couple of things that feed into this. So when we look at tissue load capacity, we're looking at things like strength control, flexibility, tissue sensitivity, biomechanics, running gait, and previous injury. All those things are going to play a role. And then we think about training load. What is someone doing? And we touched on this, but it's more like, volume, intensity, frequency, type. It's probably, we're going to touch on this as well later, but probably where the 10% rule really falls down, rather than just looking at weekly training volume, we need to actually start taking a bit of a deeper dive into what does someone's training actually look like? What are they doing outside of running? Things like work habits. What do they do that they may not think is load? And I think that's often something that when we ask someone, drill down to what they're actually doing, there's probably a lot more things that are feeding into their training load than just simply running.
Yeah, for sure. Like, something like cross training, a lot of runners now sort of in this little bit of a cross training buzz on social media. Everyone's got some sort of like a Peloton bike at home or something like that.
Yeah.
So, how does that impact their ability to recover for their next run?
Absolutely. Rest days are so important. And I feel like sometimes when you're talking to runners about their rest day, it's not actually a rest day. It's just subsequent. It's different load, but it's not running load, but it's still load on the system. Yeah.
Yeah, an hour on the Peloton bike is not rest. Your quads are shattered, and then if you do a downhill run the next day, you'll feel it.
Absolutely, absolutely. 10% rule, I think everyone's heard of this. I would hope that we're starting to move away from this, but it's something that I still see a lot in the clinic, Adrian, where someone says, yeah, I've been tracking my load pretty closely and I've been increasing it by 10% each week and thinking that that's safe and appropriate. And I think, I hope that people are getting out of this, that there's much more to the clinical picture. And we touched on it earlier, but intensity, frequency, terrain, type, all of that plays a role. And I think a really nice way to explain this practically to patients is, well, what if you're only doing 10Ks a week? If you're only doing 10Ks a week, well, 10% isn't a big change. It's not a huge load to increase on the system. But subsequently, what if you're doing 100 kilometers a week? Adding 10 kilometers to someone's training load if they're already running 100 kilometers is a hell of a lot, and it's probably a really nice way for patients to have that moment where they think, okay, I get this. There's more to it than that. You still seeing that in the UK, Adrian, the 10% rule?
Yeah, everyone sort of comes in with the 10% rule, and it's the thing that there's a fundamental error that I see when runners and run coaches come in going, yeah, I'll just increase him by 10%.
Yeah,
is that you're just looking at mileage. You're not factoring the whole thing. So firstly, the rule is flawed, and I'll talk about that in a minute. But if you look at how training load is calculated with the original work from Tim Gabbett, is that it's not just the volume or the time spent running, it's also the RPE, the rate of perceived exertion.
Yeah.
And that can change on any given day. You could do the same run for 60 minutes every single day, but your recovery every day will affect your RPE, your mental health. If you'll have stress, anxiety, things that work, other things that are distracting you will have an impact on your RPE as well. So, that 10% is you got to factor in the perceived exertion, which no one does. So, that's when you go, that sort of 10K on 100K might be, for some runners might be okay. And then for other runners, it might not, because they might have a ton of other things going on. And, an extra 10K might just take their training load up by 40%, for example, like in just a hypothetical number.
Yeah.
So it's important to sort of understand how RPE plays an effect in that as well.
Absolutely.
And then secondly, we know that, the 10% rule is not sort of, it's flawed, and it's sort of been sort of proven, I guess, not wrong, but not accurate either.
Yeah.
So, that's the work coming out of UTS in Sydney by Franco and James Coots. I'm not going to even try to attempt to say Franco's last name. It's about like half the alphabet, but he's an absolute brain and wizard. And if you don't know who he is, you should Google him and read his work. But yeah, every athlete is a little bit more robust than the other. And what does that mean? It means that some athletes might be bang on in terms of 10% and is what they might tolerate in terms of like a workload increase. Some athletes are a lot more robust and might be able to tolerate 20%. And then you might have an athlete on the other end of the spectrum where they might be only able to take things up 3 to 5% every week. So you really have to, give it an individualized look.
Yeah, absolutely. You touch on this, mate, the acute chronic workload ratio. And I think, just a little caveat to this, it's not perfect either. And we know that. And some of that research that has come out has, highlighted that it's not perfect. But I do like looking at this and with a runner, and I certainly like looking at acute versus chronic load. And if we're looking at, we know that there might not be necessarily a sweet spot, because that might change, like you said, between individuals. But if we look at acute load, which is defined over a shorter period of time, it might be a week in this case. And then we look at chronic load, and we're looking at a rolling average over a longer period of time. So it might be over 4 weeks, 6 weeks, for example. I think what we want to highlight is someone can have higher chronic loads. And what I'd probably say by high is probably reframe that to consistent chronic loads. We know that's probably subsequently going to be more so protective against injury within reason, if it's not too high. That if someone can run consistently and expose themselves to load over a longer period of time without getting injured, it will build tissue capacity. And we know that helps. And then if acute load goes up too quickly, we know that the body doesn't like rapid changes in load. That can increase someone's risk of becoming injured, or may increase someone's risk. So although we're saying that, hey, it's not perfect, I think it's a much better way to start looking at loading within the runners and taking a bit of a look at, hey, how, like you said, rate of perceived exertion, how hard was that run? Let the runner rate that, because that can change day to day. Look at the type of runs they're doing. Look at the frequency they run at. Are they running every single day of the week? That's going to play a big role on someone's ability to recover. So I really like looking at this. We're not going to dive on it too much. I'll take a deep dive into this, but just know that, if someone can run consistently over time, that can be somewhat protective against injury.
Yeah, there was a good paper that came out at the back end of last year where they looked at athletes that picked up an Achilles injury. So it's a Dutch paper. There's got a few flaws in terms of, it looks at runners running a 5K event all the way to a 42.
Yeah.
So, but they looked at, runners entering these races, and they said, if anyone picks, they did the Visa A, which is the Victorian Institute of Sport questionnaire. And then they looked at, if an athlete picks up an Achilles strain, how likely are they to get ongoing symptoms throughout the year or 1 year post the onset of symptoms?
Yeah.
And what they found in the research was that runners that ran higher volumes and ran the longer races were less likely to have those symptoms, within reason of controlling running volume from speed, intensity, and frequency of runs. So, there is definitely a protective effect there.
Yeah.
But just even sort of touching on this slide here, like Alex said at the start, it's just important to know, like, understanding where your runner has been and why they're there in front of you, right? Like, there's might be the running load, their running history will tell you a lot about this runner. So, have they been one of those runners? And, I've seen this a lot on Instagram, and runners that come into clinic is, you'll have a runner that comes in and in 1 week they're doing, 60 Ks, and 1 week they're doing 100 Ks, and they drop back to 60 Ks, and they drop back to 100. And then the next week they're back up to 120, then they dip to 80 K. And this sort of spike in workload, if you think about what that adaptation is going to have on something like a tendon or a muscle, there's not going to be any consistency, right? So if you compare that to, say, probably one of the best runners in the world right now, Kipchoge, this man runs 200 Ks a week every week.
Yeah.
Right. So, there might be differences in terms of the types of training and stuff he's done, but there's also a level of where they've built up to that. Like, it's been a slow increase. It hasn't been this spike of getting them there.
Yeah.
So we need to understand that trend of running and how that trend is affecting the runner in front of you. And, most of the time it's going to be affecting them in a negative way, where they're going into increased fatigue and they're picking up some niggles.
Yeah.
But there might be that odd runner who's just bloody robust and resilient and just can tolerate spikes and lows, and they just coming to see you for performance changes.
Absolutely. And I think if we go back to, some of the social and some of the psycho around, treating runners, well, what other life events have they got going on? Have they had a period of high stress? Have they had a period where they're not getting a lot of sleep, and has something impacted their ability to recover? Their training load might be the same, but their ability to withstand that load might be subsequently reduced because of other factors that are going on in their life. So I think when we're looking at that, we always come back to, hey, what does the person in front of me have going on in their life? Not just looking at the running, not just looking at the biomechanics, but let's treat the whole person. Let's have a really, really good look at that and treat the individual in front of us.
Yeah. We won't spend too much more time, but the other thing that also, like Alex said on that, is like, they might not have changed anything from like the volume, but they might just be trying to cycle in a new pair of shoes at the same volume. And, shoes can have an impact there if they're a different brand, make different heel drop.
Yeah.
So just understanding that effect. And I guess lastly, also to touch on those, like, if they are spiking and still robust, you still have to sort of, like, within reason, educate that person and go, look, you're doing okay at the moment, but you might not be doing okay in the future because this may or may not catch up with you. And, educating them around the importance of having consistency and having good sort of build up in their volume and, deloads and phases in their training as appropriate.
Absolutely, mate. All great points. I think, super, super solid, and it's not perfect, but hey, we need to definitely look at those rapid changes in load as being somewhat influential on injury risk. Sleep. I love these studies, mate, and more of this keeps coming out. You may be far more across it than I am, but I really like this study, and fairly recent, particularly the Johnson study, but looking at athletes who sleep less than 8 hours a night being a 1.7 times greater risk of suffering a sporting injury. I think that's really important. And then looking at athletes sleeping an average of less than 7 hours over the past 2 weeks, they're actually at a 51% increase of sustaining a new injury, and that was in endurance athletes. So we know that the importance of sleep is being recognised not only in injury risk, performance, even outside of running, and how protective is on just many factors, in the human body. But I think it's a really, really big one. And if we're not asking our runners, hey, how much sleep are you getting? Or is there things in your life that are maybe impacting your sleep, particularly when they have been injured or they've come in to see when they're uninjured? I think we're leaving a lot on the table there. I think it's a massive part of providing value to the running population.
Yeah, no, I agree. Apparently, if you Theragun though, you don't have to worry about sleep. You're all good.
Exactly.
No, mate, I completely agree. And, I'll give you a reference. An example here is like not a runner, but, elite athlete on the top of his game. Lebron James is someone who's notoriously known for having a midday nap, trains the house down. Man's 36 years old, best player in the world still to this date.
Yeah.
But prioritizes his rest, recovery, and sleep most importantly from all of that. So he's angel investor in apps like Calm and things like that for things like sleep and headspace and mindset. So sleep is crucial, and it's your best tool of recovery. A lot of runners are investing in freaking vibrating foam rollers, Theraguns, Compex machines, all these different things where the research is piss poor. And typically always sort of funded by the actual company. So you got to look at research bias there. But if a runner is not really prioritizing their sleep, and it might be for reasons within their control or without their control. So, a perfect example is a runner that had great sleep and then all of a sudden they've just had their first child and now has to wake up 3 times through the night to take care of their child, but they're still trying to keep up their running load because running gives them a mental release. It's like you have to tell them or show them how this might be impacting their running.
Yeah, absolutely. And I think one important point on some of the sleep stuff is letting people know that they can't bank sleep is really important. So you can't have 4 hours sleep Monday to Friday, get to the weekend and say, oh, I'll get one day in there where I'll have 8 to 9 hours sleep and thinking that, hey, I've caught up. It doesn't work like that. It's just like your training. We want to have consistency over time. So trying to get, ample sleep throughout your week is really, really important. Psychological factors, mate, I think is massive as well. We know that stress plays a big role in the perception of the painful experience. And even beliefs around injury and training can play a huge role in someone's, not only their perception of pain, but also their beliefs around training load can impact their training itself. So addressing these psychological factors, I think, are huge. And again, it comes back to treating the person in front of you.
For sure. Like, especially in the day and age we live in right now, like Facebook, Instagram, and so many runners and running influencers sharing their opinions. And, runners are very sort of like clannish, cliquish people. So if an influential runner says something and they go, oh yeah, this is why I got injured, everyone's going to think the same thing. So people come in with some pretty weird and wacky beliefs. So, really understanding why they think they're injured. Like, how often do you go to a runner and go, why do you think you've got yourself hurt? And some of them might go, I don't know, that's why I'm here. And then others will give you, an essay type response, and then you just sit there and you look like that mind blown emoji. You're just going, what the hell is going on here? Like, what have you been reading? Even Wikipedia is more sound than this. So you just got to like factor that in for sure.
Absolutely. And navigate that in such a way that we're, really providing great quality care and education. Again, here's the big one, biomechanics. So we know it plays somewhat of a role. It's necessary. We're not saying that, hey, just forget biomechanics. It does play a big role in running injuries. But we want to even touch on some of the research here and say that, again, there's more to it. There's got to be more to it than just simple biomechanics. Having said that, we just want to touch on some of the things. Like we know that running it's a sport that involves multiple and sustained loading cycles over time. You're on one leg or none when you run. And so there is load going through the system when someone moves. And is there ways that we can, shift load around when someone is injured? And is there ways that we can make someone potentially more efficient, potentially, and also, reduce some of that loading going through certain structures? And particularly we see some of the research on gait retraining. We can deload things like the knee, is a really good example of that. But some of this research, so there was a 10 to 15% higher loading rate found in runners with stress-related injuries. Now, we know that there's often more to it than bone stress injuries, and we know there's more to it than things like MTSS and shin splints. But, there was in one study, there was a 10 to 15% higher loading rate there. And there was another study that looked at runners that had no injury history, had significant lower impact peaks and vertical average loading rates. Again, I would suggest that there's much more to it than that. But we want to present a little bit of this stuff, knowing that, hey, there is some evidence out there, particularly with things like overstriding that's going to be in the next slide. But they're multifactorial in nature. Don't forget the human. Don't forget the biopsychosocial. That's probably the most important takeaway here.
Yeah, for sure. And look, addressing biomechanics in runners is just one element of what you'll do.
Yeah.
Like Alex said, you're shifting load around. So if you're, working on something like a cadence change, and we'll talk about this as well, is, how is that impacting someone's running, and will there need to be an appropriate strength plan that needs to go with that?
Absolutely. This is another paper that's showed that some of the biomechanical factors that may be most prevalent in runners who do sustain an injury and overstriding. So running around with an extended knee at initial contact and more dorsiflexion at initial contact as well. Contralateral pelvic drop, hip abduction, and excessive forward trunk lean may contribute to increased risk of injury. And I would say may, but it was highlighted in that research. I liked when we spoke about this, Adrian, off air. I liked the conversation that we started having around, well, what role does pain inhibition have on some of these mechanics? When we're studying injured runners, are they altering some of their mechanics because they're in pain? And often, it's kind of like correlation versus causation. We see that a lot in the patellofemoral population as well, whereby, we see that once someone has patellofemoral pain, we might see that they've got a pelvic drop and increased hip adduction moments at mid-stands or from initial contact to mid-stands. Having said that, we also see runners who exhibit those exact same signs and don't have patellofemoral pain. So it's often a correlation, but not a causation.
Yeah, definitely. There was a patellofemoral sort of like consensus statement that came out at the end of 2019, if I'm not mistaken, if I haven't got my years mixed up. And that was by Rich Willie and that group. They're out of Montana in America. So that what they found with the research, especially at the hip level and the lateral hip, is the evidence around sort of like strengthening the lateral hip was quite weak in terms of what that meant to patellofemoral pain. And the author sort of highlighted to say that, is this something that we're doing as an adjunct to sort of distract potentially? And Rich really talks about this in podcasts as well. He's like, are we potentially doing this to distract people and maybe load something else up while we're getting the knee to settle down?
Yeah.
So, it's not all in the glutes, right? It's like the classic, like physio runner, any sort of therapist seeing a runner and going, oh yeah, you need glute strengthening and you need core strengthening, is like, no, stop for a second. What we know with something like patellofemoral pain is obviously understanding load is going to be crucial, the types of load that they're putting through it and how we can modify that.
Yes.
And then, just, like you hinted on before as well with pain inhibition, it's is pain actually causing the issue, or is it the other way around? Like, and you wouldn't truly know unless you saw this athlete before and you've got like really good baseline data, and then you see them when they get injured and you compare that baseline data to their injured data and you go, okay, cool, we can see a change here. But we don't always have that luxury.
I think, going back to some of the literature around, strengthening the lateral hip and trying to control things like pelvic drop and hip adduction, that we probably see that stuff doesn't necessarily change kinematic variables. But, we know that often some gait retraining tools can have an effect on some of those factors as well. So, patellofemoral joint and particularly around the knee, some really nice gait re-ed tools or gait retraining tools that can have a direct effect on shifting some load around the knee and reducing some load at the knee. And so, we can probably address it more so through some gait retraining whilst we're building load capacity in some of that tissue, around the patellofemoral joint as well, with some good quality strength and conditioning and things like that. All right, how do we assess runners? So we know it's a highly repetitive sport. We're interested in the force that's applied to the tissue, yes, and we also want to look at some of the joint angles. So a big thing with the running room concept and what we've tried to do is we always want to have accurate data for our patients, but I think the biggest thing for us is we always want to have data that's actionable. We want it to drive intervention and that may have a positive impact on someone's injury or their rehabilitation, their prehabilitation and performance. So we know that that's got to be in conjunction with a good strength and conditioning program. We see the literature is supportive of that. Good quality strengthening programs can have an impact, a direct impact on injury reduction and performance. And I always like speaking to this, Adrian, that it does make us accountable as therapists. If we're assessing someone with good objective data, we can't get them running up and down the hallway and say, oh, that looks better, mate. We want to be able to deliver data that, hey, shows that, hey, have we made an effect on ground contact times or shortening your stride, or, are you not overstriding as much, things like that, as well as, symptom abolishment. And then always providing, the tools that we know hold huge value in terms of managing injury and also performance.
Yeah, for sure. Like you want to be able to show them something, like whether it's being able to lift more weight or whether it's being able to sort of get their overstride corrected, and you can show that to them. With if you have an instrumented treadmill like we do, and we're quite fortunate, we can show that to them with the data on the treadmill. But you can even use some really good apps on your phone, like Huddle, and play around with angles and joint lines and show them some really nice changes to say, okay, look, this is where you were, this is where you're at, and then couple that with their subjective presentation and say, yeah, I actually feel a lot better. They'll go, my pain was a 7 and now is down to a 2. So, you can marry up the subjective and the objective data.
Absolutely, mate. I think you touched on a really good point. Like, we are super fortunate to have an instrumented treadmill, a treadmill with a pressure plate under the belt that measures this stuff really accurately. And we use a high-speed motion capture, semiotesis, with some active markers, which we're going to show everyone here on this presentation. We're actually going to do a live running assessment. But I think you make a really good point that you don't need this stuff to assess runners. You can use other things that are effective. But yeah, it's about really being, I think, be able to show the patient, empower the patient that, hey, we have made a change here, motivate the patient to buy into the stuff that we know is going to have a profound effect as well. Not just looking at someone's running, making a biomechanical change. We need to couple this with good quality strength and conditioning and education on load management and other factors. We're going to skip through this, mate. I think we're going to touch on this in the live demonstration. So let's go straight across. I wanted to really look at this, and this is something that we are super passionate about, and really, the research just keeps adding up in the running population. And that's the role of strength training in runners. I think it's probably one of the most powerful interventions we have, with the exception of education. I think that strength and conditioning in runners is such a useful and powerful tool that potentially runners have had a little bit of pushback in the past. I think they're catching on. I think, it's getting better and better, but I still see clinically a hell of a lot of runners who maybe not doing the best things they could be doing with regards to strength, and also maybe having some poor beliefs around strength training in general. And I think one of them has always been, I don't want to put on too much muscle. I don't want to put on too much size. And I think there's some really good literature here that, shows that that strength training has the ability to increase running economy and increase performance. The really nice systematic review with 24 studies looking that strength training has the ability to improve running economy by 2 to 8%, improve time trial performance by 2 to 5%. So, often when we see people in the clinic with coming in with, Nike carbon shoes or any other carbon shoes that are out there, and not doing good quality strength training, we often will say, hey, we might be able to give you 5% if we can just get you doing some strength. And I really like that in the same study, they found that 18 studies of that systematic review found that there was no change in body mass with runners. So body composition was unaffected in runners who complete resistance training, which is a really nice bit of information for runners to hear that, hey, this is safe. You're not going to put on weight. It's not going to negatively impact your running or your body composition. And a really powerful one here with reduced overuse injuries by up to 50%. So yeah, massive, Adrian. I know you're big on this stuff, but anything to add there?
Yeah, I mean, the data speaks for itself, and it's that's all sort of really sound research there. But I guess I'll sort of speak in a more pragmatic ways, like the person that comes in front of you, like the runner that goes, I don't need to do strength. Like the most common thing I hear is like, I don't need to do strength work because running is making me stronger. And then you have to sit there and educate this to your runners. Go, whilst you might run, whilst your running mileage might build up, really what you're building up here is probably some cardiorespiratory endurance, maybe some muscular endurance as well, where you're quote unquote not getting stronger. If you look at the literature in terms of strength training and how to actually get stronger through your tissue, it requires you to train at a certain intensity.
Yes.
And this might lead to a couple of things. Is like, in an ideal situation, you'd get them to lift some good heavy weights, some heavy slow resistance. Someone like Chris Johnson is big on this as well. Like heavy slow resistance is key, and always the number one option. Where possible. But times like this where it's COVID, someone might not have a gym. So how do you get them doing work or exercise that's still making them work really hard or at a high intensity? And I think this is where a lot of runners go wrong, is they go, yeah, I do some strength work, I do some YouTube workouts, and they do some absolute rubbish. They're just doing some band work, some clams. Some person on Instagram who's a runner is getting them to do something on a Bosu ball and a single leg, and calling it strength and stability training. And there's a lot of rubbish out there. So you really have to sort of like sift through and talk to your runner and go, okay, what exactly are you doing and how are you going about doing it, right? And if they're doing it correctly, then awesome. But for the most part, they're not. They're doing like interval type training and HIIT training, which is not actually giving them strength adaptations. It's giving them more maybe endurance adaptations, which they're getting from running anyways. So you really have to educate them on what are they doing and what is it actually giving them, and then what they could be doing better or utilizing their time better.
Absolutely, mate. And I think it's when we touch on slides like this and the amount of load that's going through certain muscle groups whilst we run, particularly like things like mid stance of running. And this is from Rich Willie. You mentioned him before, from Montana. This was a presentation he gave at La Trobe University back in 2018 that I was lucky enough to hear Rich speak. And if you haven't looked up any of his work, or listen to any of his podcasts, another guy that speaks really, really well and has some absolute nuggets, researcher and clinician himself. But we often hear about the glutes, and I think it's something that we need to move on with a little bit and start looking at, well, what muscles playing a huge role when we look at the runners, and so the calf complex and the soleus, huge role in anyone who runs, and we see that. Maybe some of the engagement of other muscles does pick up at running higher speeds, but it never will exceed that of the calf complex. So your soleus is really exposed to high loads, 6.5 to 8 times body weight force. I've actually seen it higher in some literature there as well, up around the 8.6 mark. So it's a massive thing that we need to prioritize. I mean, I still see a lot of runners, Adrian, who come in and aren't doing any calf work. And if they are, they're doing potentially straight leg calf raises, and maybe sticking with 3 times 25 reps with no weight. And if you just look at some of the loading that's going through the soleus here, we know we need to target that muscle with a bent knee, number one, and we need to make it above body weight. We have to put some external load on the individual here so that we're trying to reproduce or trying to exceed body weight, because that's what's happening when someone runs. That's what's going to give you those gains. That's what we see in the literature in terms of performance, that some of the heavy slow resistance training is so powerful as a tool to not only increase performance, but also increase tissue capacity as well.
Yeah, no, I think you hit the nail on the head there. Like, people aren't doing the appropriate work. They're probably focusing more on straight leg calf raises. And if you look at then the quality of it, they're not really holding on to something. They got like a fingertip, and it's a strength exercise. It's not a balance exercise. So,
Yeah.
get your balance, get yourself steady, and then, do the exercise with good technique. And even in, people aren't really doing that. So really talk to your runners and educate them with that. And then there's also a huge sort of population of runners that go, I don't like lifting weights. I don't like going to the gym. And you don't have to lift heavy weights to actually get a strength effect from your work. Like a Soleil's calf raise on a step with, a backpack that has a bunch of things from your pantry can make you work bloody hard. And you don't have to do 25 reps of it either. You could be doing 3 or 4 sets of 8 reps, and you're getting an amazing strength effect if you're controlling your variables really well.
Absolutely.
So, be creative with how you approach your runner with the combination of like power resistance bands, backpacks, weights, and whatever they have at their disposal or they're happy to use.
Absolutely. And something that I'll educate my runners on a lot, Adrian, is that it actually is easier in some sense to give them heavier loads because they don't have to do them every day. And, it's something we see. The biggest issue with giving someone any form of exercise as a clinician is compliance. And so if we can say to someone, hey, you don't have to do these every day. This is a 2 to 3 times a week type of activity. And we see that when someone's in season, to maintain those gains, often we only have to do them once a week, to maintain the effect that strength training would have had, the positive effects. And so often it's really refreshing for runners to hear that. Oh, I don't have to do these every day. No, you don't. And I think the other thing is, not only if we can shift away from injury, runners don't care about injury until they're injured. In a lot of cases, they care about performance. So if we can say to them, hey, not only is this going to decrease your risk of injury, it's also going to improve your performance, runners are more bought in. Okay, cool. You're telling me I have to do them less, but it's going to increase my performance and stop me getting injury so I can run more. I think that's a really nice way to frame that up.
Yeah, for sure. And I think what you said there is like 2 to 3 times a week is probably enough. And for most runners, 2 is probably where they'll be at. And that's all they should be doing. I think if you're prescribing exercise to a runner and you're saying do this every day, I would really look at the context of how you're doing this. If it's a runner that's injured, has really, really poor tissue capacity, and you're working from a pain resilience perspective, maybe there's a rationale there to train them every day. Yeah. But if this is a runner that's still running and, has a niggle, for example, and running 4 or 5 times a week, and you're saying do this every day, firstly, are they going to be compliant enough? But B, are you actually making your runner worse because you're overloading tissue? They're doing exercise, they're doing exercise and running, whereas previously they were just running. So now, are you actually getting them stronger, or are you actually putting them into an increased state of fatigue and making them actually go from a niggle to being fully blown and injured?
Yeah, absolutely.
So you need to factor that into play. And then the last thing that you mentioned is absolute gold. You need to connect it to the why. Like if you tell someone why they're doing something, they're more likely to be compliant. And this is not a runner thing. This is a general thing with anything in rehab.
Yes.
If you say, here's a deadlift, and the reason why we're doing this deadlift is we want to strengthen your lower back, and that's going to have a profound impact on your back pain and your ability to interact with your children. Yes. Bang, that's the deep why there. Yeah. You're connecting it, and then connecting the same thing for your runners. Like, cool, I'm giving you these heavy resistance step ups because you've struggled with your uphill journey on your runs. And we know your next race has an uphill battle, and you're trying to hit that sub 2:45 in your next marathon. This is going to be part of the picture to help you get there. Okay, cool. This is really important to me. I'm going to execute it.
Absolutely. I love that, mate. Come back to the why. Super, super important. It's that patient-centered care. Just quickly, the strength and conditioning component, I think, as a really general kind of idea, this is something that we've developed and something that we've brought out from what we see in the literature. But running fundamentals, it should be heavy, slow resistance. The reps should be lower and the weight should be higher. So we don't want to give someone body weight 3 sets of 25. We actually want to lower those reps and use some weight. We always focus on some compound movements. Let's keep it simple. We don't need to reinvent the wheel. We see in the literature that some simple exercises work really, really well. A deadlift and a squat is a great starting point. We want to focus on some single leg exercises. When you're running, you're on one leg or none. And that can include things like single leg squat, lateral toe taps, one of CJ's favorites, a lunge, a single leg bridge, a step up, all those movements that are going to focus on strength, but also some coordination and some movement around the trunk control, hip control, knee control, foot and ankle. Going through those patterns, I think, are important as well. Calf strength has to be in the program. It's got to be both bent leg and straight leg. Do not forget the soleus there. Throwing some core. And then I also think like exercise specific to their running related injury if they are injured. And then we want to go down a little bit of that plyometric continuum, some power-based training as well. But I think if we're focusing on the compound movements, single legs, calf strength, you can't really go wrong as a starting point for runners.
Yeah, no, I agree. I think, look at all of this and look at the intensity, the RPE of how hard they're working, and then accordingly prescribing the right amount of sets and reps. Don't go for your classic 3 of 10. 3 of 10 isn't wrong if you're getting the RPE right, but for most times people don't.
Yeah.
And then last thing you touched on there is that power plyometric training, which is important. But once again, you need to understand that it's really, really short sets and reps with power plyometric work. You might be getting someone to do like 2 sets of 4 reps. So if you are prescribing those sort of things, is understand the energy elastic sort of reserve that someone will have.
Yeah.
And you can't be getting them to do like 4 sets of 20. Is that, it's just going to be piss poor effort.
Yeah. Yeah. Mate, I think we're going to wrap it up there. Let's dive into a bit of a running assessment. And I'm going to throw someone on the treadmill now and look at how we look at things biomechanically and maybe have a look at, is there any quick wins for this runner? Can we implement a little gait retraining tool, and what effect does that have on some of their mechanics? So let's dive into that. Adrian, I want to thank you for your time. I really appreciate your knowledge. I appreciate you as a person and a clinician. And I really appreciate your ability to educate clinicians and present the research in such a practical way through freshmen.
Thank you, man. And thanks for having me. Hope you guys enjoy this and what's to come as well.
Thank you so much.
Cheers, mate.